It's going to be a little offbeat topic, offbeat in the sense human factors in orthopedics. I express my sincere thanks to all my colleagues. So as per the Institute of Medicine report, around 98,000 deaths per year in US hospitals due to medical errors. And this accounts for a jumbo jet crashing every day for a year and killing all the passengers. So that is the magnitude of medical errors. At least 4.2 million people die each year within 30 days of a surgical procedure, as per a study published in Lancet in 2019. And the data from the NHS England shows the number of medical errors is staggering 237 million medication errors in 2018. So I had a bizarre beginning as an orthopedic surgeon when I started practicing. There was a polytrauma case that happened, and a patient was brought to me with fracture shaft of femur, tibia, and humerus, maybe violating the principles of damage control orthopedics. I just went ahead and fixed the fracture shaft of femur and tibia. The same night, heroically, I thought things were going well, and discharged the patient. 3 months later, the patient came with a broken implant in the femur. Then only I realized that I put left-sided proximal femoral nail in the right femur. Probably this was my first encounter with human factors. So what exactly is human factors? See, I'll explain a situation. A cardiac arrest happens in the ward, code blue is announced, and the team arrives. They try to connect the newly arrived pads to the defibrillator, but the attempt fails and the patient dies. So this issue at man-machine interface is called human factors. So in the early writings of Hippocrates, we saw glances of human factors, how surgeons' workplace should be designed, how the tools should be arranged. Even the medieval castles, the staircases are arranged in an anti-clockwise fashion, which makes it difficult for the enemies to climb to the upper levels. Moreover, the staircase is poorly lit and narrow, which makes it extremely difficult. Kind of a brilliant design thinking. So this we can find even in our traditional stories, where Duryodhana had a fall because of the design of the tiles, which resemble that of a pond. Of course, design flaws we see in everyday life. What exactly is meant was white glass coffee, but from the other side, it shows something different. Vecuronium and vancomycin, verapamil and naloxone, midazolam, ketamine, phenylephrine, ondansetron, so many examples we can suggest. Now, coming to a case, surgeon was doing his first robotic TKR. Surgery went on fine, although with some technical glitches, and team celebrated with an on-meter visa, only to realize a few weeks later a catastrophic infection. So, going by Swiss cheese pattern, we understand that there are multiple causes for this, but one issue I would like to pick up here is the OT nurse was critical about the hand washing technique of the newly joined nurse, but she was not willing to come out with this issue. The red flag sign was ignored. Actually, the staff should be empowered to speak up. Another issue that is here is the senior surgeon's complacency in aseptic techniques. Even if his hand touches any unsterile area, he usually proceeds, and nobody was willing to raise this issue. And this aspect is called as normalization of deviance. You might have seen this video. The Challenger exploded in 73 seconds after launching. NASA was very well aware of the issue with the O-rings. However, it was ignored due to production pressures. And they went ahead and Challenger exploded. So basically, deviation from the normal practices, protocol violations, and hierarchy of gradients in OT, all these things are issues, and we need to come out of this. So the suggested algorithm is PACE approach, like probing, which is known as hinting, alerting. Alerting is directly stating that a problem is existing. Challenge describes a problem with a potential solution, and emergency means a stop is to be called. So this is how somebody who is with junior in the hierarchy can alert the surgeon about the potential problem. Otherwise, never compromise on sterility, otherwise you will end up with disasters like this. So here there is one thing, there should be clarity in the discharge instructions. A longer cast was applied in OPD, developed numbness in the next day. He removed the cast by himself and applied hot water until the skin got burned. Kept off peeling the tissues, and finally the result was disastrous. So clear instructions, clear communication with the patients is mandatory. Here is a case of bilateral simultaneous TKR where right-sided femoral component was used on the left side. And this is not uncommon.